Welcome everyone. Let me introduce my PhD topic, which is improving the success rate in the surgery of chronic middle ear diseases. My name is Kata Illés, and I'm currently working in a department of otorhinolaryngology, head and neck surgery in the Bajcsy-Zsilinszky Hospital next to my PhD work. My vision is clinicians use the most effective therapeutic options in the field of middle ear surgery, and my mission is to investigate these options and create high level of evidence. Here is a list of my current work. And the first topic what I was working on is about mastoid obliteration. Here you can see the title of my article. The mastoid obliteration decreases the recurrent and residual disease. Here is the manuscript status, and it was submitted in 4th of May, and now it's under review. Many of you have a chance to listen to my previous presentation in the progress report, so I would like to show this graphical abstract for you to be quick. So my aim was to evaluate the effectiveness of the mastoid obliteration comparing the conventional technique. And in the picture, you can see 3 pictures. And the first one is the drilled mastoid cavity. The second one is the collected bone. And the third one, the mastoid filled with this bone pate, but it can be replaced any synthetic material as well. And in the conventional method, we didn't put anything in the mastoid. So we did the systematic search, and you see the flowchart of the selection, and we could do analysis on recurrent and residual disease rates, and it turned out the mastoid obliteration could significantly reduce the recurrent and residual disease rates compared to the conventional method. So this is a safe and effective method. However, randomized controlled trials are needed to confirm our results because all of these articles was retrospective cohorts. My second project is the predictive factors of the Taipan tympanoplasty. But what is the Taipan tympanoplasty? It is a procedure to repair the perforated tympanic membrane without the need to reconstruct the ossicles. The prevalence of the perforation is 9 per 1,000 per population, and the success rate is usually around 77%. However, the range is very wide. It could be even 40 or 90%, and that's because various factors have an impact of the outcome. And we would like to evaluate these factors and identify most correlating ones. So our clinical question is, how can we predict the outcome of the Taipan tympanoplasty? And the patients of our target is the patients who underwent the Taipan tympanoplasty. And there is a group of patients with the suspected predictive factors, and we would like to compare with the lack of these factors. The main outcome is the success rate, which is the number of the full recourse tympanic membrane expressed as a percentage minimum 12 months after the surgery. And the secondary outcomes are the hearing results, such as the air-bone gap and air conduction. Here you can see the systematic search and the flowchart of the selection. In the beginning, we have a huge pool, and we could identify 40 eligible articles. And here is a list of the analyzed factors. Some of them we could do qualitative analysis, and some of them we could do only quantitative analysis. And 4 of them was identified as potential predictive factor. These 4 was the age, and we compared adults versus children, the opposite ear condition, the size of the perforation, and the skill of the surgeon. So here is the results about the children age, and we can conclude that the children under 16 years have a decreased success rate. Also, here is a result about the perforation size, where we compared larger and smaller perforations, and the perforations over 50% of the tympanic membrane reduced the chance of the success with 50%. And here is a third outcome about the opposite ear problem. The disease opposite ear means there is a problem with, there is a tympanic membrane perforation or cholesteatoma or chronic otitis media in the other part, in the other ear, and it's reduced success with 70%, and it's a very large number. About the secondary outcome, so there is 11 decibel improvement can be seen between the pre and post-operative air conduction, and there is a question: what is what's influenced the hearing? And we could say the functional success, which is the anatomical success supplemented with the hearing results, follows the anatomical success, but it's always lower than the anatomical one. Here is the summary of my study, and the main strength was a high number of the included studies, and we could reveal new clinical aspects, and we use rigorous and thorough methodology. However, there is a limitation. We couldn't reveal the connection between this factor and do multivariate analysis. Therefore, we suggest that for the further researchers to do analysis on these factors together and reveal the connection between them. And the implication of the practice is that the clinician should be aware of these factors, and it could help with the clinical decision. And my third project is about hyaluronic acid fat graft meningeoplasty. The meningeoplasty is also a type 1 tympanoplasty, and we would like to investigate two non-invasive, minimal invasive methods. One is the fat graft, which is we put fat in the perforation, and the hyaluronic acid fat graft is also the same, but we put a lamina soaked with hyaluronic acid, and it improves the epithelialization of the membrane. And this last one is a new method. It was introduced in 2008, and there is a lack of knowledge, and we would like to provide more data on hyaluronic acid fat graft effectivity compared to the fat graft meningoplasty. Here you can see the clinical question. So does the hyaluronic acid increase the success of the fat graft meningoplasty? And our hypothesis is that the fat graft hyaluronic acid meningoplasty is superior than the fat graft. So the clinical implication would be increase in success rate. And here is our inclusion and exclusion criteria, the interventions again, and the primary outcome would be the success of 12 months after the surgery, and the secondary outcomes are the hearing outcomes. And here is my three project again. One is have been submitted, and two will be in the summer. And thank you so much for your attention.
Congratulations, Kata. I really liked your graphical abstract. That was an excellent idea. And my question goes to, I have one comment. On your forest plots in the second project, yes. You didn't put a legend on the x-axis. So favors this, favors that. So, yeah. I mean, just a very humble comment. Okay, no, that's it. And my question, possibly I was superficial and I didn't listen to your talk carefully, but all these predictive indices that you identified, was it identified from a large pool, or were these arbitrarily defined by you and testing those four or five predictive measures?
Pool. Yes.
From a large pool?
Yes.
Okay, so they were not arbitrary, but you identified those?
Yeah, there is 40 articles of this project, and from these 40 articles we collected these factors, and we identified the significant one. So that 4 was the most important and significant, and all the other was not significant or controversial.
If I may just ask one more question, yes. Mr. Chairman, okay?
Yes, of course.
So, regarding, because we've been struggling with like measuring the success. Was it uniformly defined in each article? Because we've been struggling with this, that in our studies, all the outcomes are so heterogeneous. Everybody defines things differently.
Thank you so much for the question. In this case, it's very easy. You can see in the first slide of this project, the picture of the tympanic membrane. So if it's healed, that's a success. So it's a very clear definition. If it's healed 100%, that's success. If there is a hole, that's not. So it's very precise.
Thank you very much. I was always impressed by these studies, the clinical implication. It's very useful for the patients. And I just want to know what was the reason you cannot do the multi-regrade regression. What was the reason? Because if we can do this, we can adjust by age or gender, some other parameters. And so what was the reason? Thank you.
That's a good question. So, because the population of these outcomes are not the same. So, for example, here there is 6 of 7 articles, and in this case there is 7 other articles. So we couldn't do we use the same population, and that's why we couldn't do the robust ranking. And also these articles we use only raw data. So these outcomes we conclude and we do the maths. So we couldn't do more precise statistics because we don't have more data than this.
In your last study, I mean that you are going to use hyaluronic acid.
Yes.
Now, not all hyaluronic acid was born to be the same. I mean that there are different types. So what type of hyaluronic acid would you use? I mean cross-bound or free, or what concentrations and so on? Is this important?
Yes. So in the previous studies, they use one kind of lamina soaked with this hyaluronic acid, and it's produced by one pharmacy. And we would like to use that because it's already proven to be effective and it's safe. So we would like to use that specific product from that pharma company.